Thank you, Joanne, and thank you, Karen, for the introduction, and thanks for the opportunity to come together this morning with our academic partners. I know that from time to time we do meet up and exchange views around the programme, but I think from a palliative care and partnership point of view, we would really welcome the opportunity to have some kind of formalised engagement with the academic sector. And we have talked about this from time to time at our regional programme board. And you'll see our structures in one of the later slides, but the opportunity to understand the clear opportunities around research that we could take forward in alignment with the programme would be really, really important to us. I think one of the bedrocks in terms of building our palliative care and partnership programme has been the work that we initially did around needs assessment. And I think we've been a little bit constrained over the last couple of years in coming back to that. But we have tried to make a concerted effort over the last number of weeks to regroup around the issue. And I think your input into that kind of field in the future would be really valued. Kind of just move on to the next slide, and maybe we'll touch on some of the policy context in Northern Ireland in respect of palliative care. And everybody, I'm sure, will be familiar with Living Matters, Dying Matters, and the recommendations that came out of that back in 2010 now, and the years are moving on, I suppose, in terms of that extant policy directive that we've been working on. And we have been having some conversations actually with the Department of Health here in Northern Ireland about maybe the opportunities to relook at that, refresh it, and review it. So we'll see where that comes to over this year. Obviously, everybody's been very focused in the last 13, 14 months in relation to the COVID issue. So we haven't been able to develop that conversation with the department, but we do have a meeting in with them before the summer, and I'm sure that will be picked up. Obviously, at the end of that strategy period, the RQA had an opportunity to review the outworkings of that previous 5-year period, and that was back in 2015. And I think we were very positive about the RQA report. It didn't necessarily flag up the need to move into another strategy period or another strategy development, but it did give us the opportunity, I think, to think around how we would want to take things forward in relation to managing palliative and end-of-life care processes. We did hold a workshop then with all the partners in Northern Ireland, and we did agree that it would be good to develop a programme, and out of that, palliative care and partnership was born in 2016. So we've been working through that process ever since. Range of other pieces of work that have been influencing us over the last couple of years. And again, Let's Talk project was very useful for us in terms of that really detailed engagement with individuals at the end of life and their families about what really mattered to them. And I know that the Institute have been able to build on that over the years, and we appreciate that very much. And then obviously some of the really major structural changes that have been flagged up within the healthcare system here in Northern Ireland in terms of the Bengoa report and systems, not structures. And those are important policy directions for us. And one of the things that is obviously coming out of that is the closure of the Health and Social Care Board as an entity, which will be happening at the end of March 2022. So there is a new planning system being developed at the moment. I'm kind of involved in some of the work streams associated with that. And one of the important work streams, I think, will be around population health and health intelligence, which will inform, I suppose, needs assessment processes. And I'm sure all around the Zoom today will be interested to understand how they can input into that in the context of population health and population health management. One of the other policy documents, which again has been delayed because of COVID, but I understand the Minister will be potentially announcing something next month around a new cancer strategy for Northern Ireland. So we look forward to hearing around that, because obviously from a palliative care point of view, we've been inputting into that process and the potential cancer recovery plan over the last number of months. So Karen, if you could move on to the next slide, we will just touch on palliative care need in Northern Ireland. And you can see there are some of the model that we have been doing locally over the last number of years. And I suppose I think back to a workshop that I was at with the King's Fund quite a number of years ago now. I think Karina Grimes and I went over and presented in relation to palliative care in Northern Ireland, but Public Health England were also presenting at that workshop, and they were flagging up to us at that stage the potential increase in deaths within our communities over the next number of years. Deaths haven't been falling for quite a number of decades before that. And obviously then we did our own research around that and modeling, and you can see there from 2016 up to 2040 an increase in deaths from 15,000 up to over 20,000. So that's a potential increase of 31%. And coming with that, of course, will be the palliative care need, and that's projected to increase in a similar fashion. So we're very conscious of the demands that are going to be on our services going forward, and I suppose that gives us the opportunity in terms of our planning processes to prepare for those. Karen, if you want to move on to the next slide, then which just again focuses on where people die and place of recorded death. And I suppose we take a positive from this in terms of the number of people who have been dying in hospital. You can see that back in 2006, it was over 50% people were dying in hospital, but that figure in terms of percentage has come down in relation to some of the processes and systems we've put in place. I think it's important to note that as deaths themselves actually increase, while the percentage is coming down, the number of deaths is probably increasing in terms of the number of people who are dying in hospital. In terms of the care home sector as well, you'll see that more people are dying in care home, and I suppose that's reflective of the supports that have been around the care home system more recently to support discharge into care homes. And colleagues will be aware of the very, very significant initiatives that are happening at the moment around the care home sector, and more to happen in that space under a number of initiatives. And in terms of other places, proxy, I suppose, for home, you can see there's a slight increase in the number of people who are potentially dying at home. And also included in there will be our hospice sector, which accounts for probably about 4% of those deaths. So I suppose the figures in percentage terms are moving in the right direction, but we still acknowledge that a very significant amount of work still needs to be done in this space. I did talk about a couple of initiatives there that are happening here in Northern Ireland at the moment, which are really important and which the palliative care programme has been very much involved with. I will note the review of unscheduled care, which has been happening over the last quite a number of months, I suppose, and it again has been delayed due to the COVID pandemic. But again, that review I think will be officially launched in the near future. But part of that is the No More Silos initiative, which is again focused on our model for unscheduled care. We've been very much involved in that process, and we're looking through a whole raft of bids that have come in from trusts at the moment. And the other big review I think that's happening as well is in relation to intermediate care and our intermediate care services. So we'll be influencing those from a palliative care point of view in the next number of months. Karen, if you want to move on to the next slide, which captures the number of patients who are in hospital on a particular day. This is a piece of research I think you'll obviously be familiar with it, coming out of New Zealand originally, but including Scotland as well. And it shows the number of people who died within 12 months from a survey date, in this case of the 5th of February 2015. I suppose we're keen to look at this, and we have, I suppose, been very focused on a lot of the research and data coming out of Australasia, really, in terms of Australia and New Zealand in particular, and see that 14% of the individuals had died within a 12-month period, whereas in Scotland, 30% had died. And I suppose this raises the question about are people being properly managed at the end of life in terms of hospital admissions, or do we have the appropriate services in place in terms of our community structures to manage them appropriately closer to home? And I think that would be the case in New Zealand, where they have a very well-developed community sector, as opposed to Scotland. And you can see our own figure, which we've inserted in there, which is 25%. Karen, if you can move on to the next slide, we'll just talk very briefly about the palliative care programme structure for Northern Ireland. Again, it's been in place under palliative care and partnership since 2016. We have a regional board. We meet probably 3 to 4 times a year. We're meeting next Monday, actually, first meeting for quite a number of months given the pandemic. We do have an accountability arrangement in place with the Department of Health, which is very useful. And I must say the Department of Health over the last number of years have been very engaged in the programme, and it's really helped raise the profile of the programme and of palliative and end-of-life care within the department. So we welcome that. And then just down in the centre there, you'll see that we do have a palliative and end-of-life care programme team here at the board. So all the professionals in the board and the Public Health Agency are involved in that. And that's been sponsored by Macmillan, and you'll know Diane, who's on the call today, as our palliative care programme manager. We do have two subgroups. We've got a clinical engagement group. So all of the clinicians in Northern Ireland are very much engaged and involved in that group. Again, that's met recently. So there's a very dynamic agenda within that particular group. And then there's a service user and carer group, and that's facilitated by our colleagues again in the All Ireland Institute through Voices for Care. And I chair that particular group. But I suppose coming down to locality level, and this is kind of our distributed leadership arrangement that we have in place, we do have locality boards right across Northern Ireland. Co-terminus with our local commissioning groups or our trusts. These groups are co-chaired by the trust director for palliative and end-of-life care, along with usually tends to be somebody from the Integrated Care Partnership. That might be a general practitioner. And the membership of those groups, generally speaking, will mirror the regional programme board membership. So there's quite an extensive membership within those locality groups, and really they're driving the programme actions that have been developed within the programme. So we've got one structure for Northern Ireland, and we've got one work plan, which we'll touch on now. So generally speaking, we believe we've got a direction of travel for palliative care in Northern Ireland. So just in terms of our key priorities, and you can see in terms of the model there and the house, the patient and family are at the centre of that. It describes in terms of all of the bricks, all of the parties who are involved in the partnership arrangements. It's really important that everybody's involved and everybody has the opportunity to contribute. And then we're building around our key priorities within our action plan, which firstly are identification, the allocation of key worker, the whole work around advanced care planning, and then the opportunity to support our individuals and patients with good generalists and specialist palliative care services. And that's underpinned by good communication and public health approach and our regional good practice guides and tools as well. So a lot in that, but we're very pleased that that's the bedrock, I suppose, of our programme here. I suppose just noting on a couple of those things, a lot of work has happened around identification. I'll come on to that in a second, particularly in relation to the key worker as well. We obviously have an operational policy in place for that. More work needs to be done around that. Again, from a Department of Health point of view, we have been doing a lot of work around advanced care planning. And you will all know, I suppose, at this stage that Karina Grimes is leading on the development of policy work around that. And we would hope to hear more about that and the launch of that towards the end of this calendar year. And I suppose just in terms of developing our workforce, always a struggle in terms of the constraints around recruitment and workforce. But we obviously are very focused on our workforce in terms of the actual delivery and the quality of delivery of service. So if we can just move on to the final slides, Karen, and just tying it back, I suppose, to the opportunities around research and our own work within the programme. And when it comes to identification, Dan Walker has been doing a very particular pieces of work in this space. And you'll note their reference to working in primary care and the development of an Anticipel app, which will sit and can sit on GP clinical systems. So that's very much focused on helping to improve identification rates. And we've seen the opportunities within that piece of work to actually significantly boost identification within primary care services. And then secondly, and looking also at secondary care services, we have been doing work across most of the EDs in Northern Ireland. I think some retrospective work has been completed in 4 out of the 5 major EDs, looking at patients who are coming in to ED and who would have palliative care, unidentified palliative care needs. And then just in terms of advanced care planning, just mentioned the policy work that's happening already around that space. And obviously you'll see the research work there noted as well. That has been very helpful for us in terms of supporting the advanced care planning agenda. I maybe just mention as well the opportunity around the public health approach in this space as well, because that's another really important area of work that we have been engaged in, again, with our department colleagues over the last number of years. Again, that's been delayed because of COVID, and it's something that we will want to get back to with, but there is huge opportunities to develop a public health approach around palliative care. And again, some of you may be familiar with the discussions on social media recently and the debates within the Assembly in relation to palliative care and the programme for government and the opportunity to have even the terms death, dying, bereavement referenced within the programme for government. So we're optimistic that we might see some changes in that space whenever the revised programme for government is released in the near future. I suppose then just looking at opportunities then for the future in terms of where we might want to think about as well. It's probably about, palliative care out of hours. That's always a challenging area for us in terms of the delivery of care and the quality of care. I did mention earlier as well the work that's happening around the care home sector and how we can, deliver care better in patients' homes, whether it be in the care home or whether it be in their actual home. And then there's something about continuity as well in relation to that key worker role. And while we have that operational policy in place and have done it for many years, I think that's still been a challenge in terms of the actual delivery of that whenever we talk to our trust colleagues in particular. And I suppose as well, we need to think about, the best ways to begin to deliver palliative care for non-cancer diseases. Obviously, we've very much emphasised in recent years, non-cancer conditions in relation to palliative care, and we're pleased to see that has been really and continues to be recognised. But there always is, I suppose, that focus on cancer, and we need to try and move that dynamic along the whole spectrum of conditions. So I'll maybe stop there